So head and neck sarcomas are rare, accounting for about 1% of head and neck malignancies and 5% of all sarcomas. These tumors may arise from either the fibrous, fatty, muscular, synovial, vascular, or neural tissues. 15% of adult sarcomas and 35% of child sarcomas occur in the head and neck, most being soft tissue sarcomas. Now, these sarcomas can arise from almost any part of the anatomy in the head and neck area, although the parotid glands, neck, face, forehead, and scalp are the sites encountered most frequently. Now, broadly classifying the sarcomas, they can be basically of two types. They are the ones either originating from bone or cartilage, or they can be the ones originating from the soft tissues. Now, apart from this classification, the WHO have classified the soft tissue tumors in the following category according to the tissue of origin. So, according to the tissue of origin, they are broadly subclassified into three types, that is benign tumors, intermediate, and malignant. Now, when the tissue of origin is adipocyte, the common benign tumors are lipoma, lipomatosis, lipoblastoma, angiolipoma. In intermediate group, it is atypical lipomatous tumor, and in malignant, it is well-differentiated liposarcoma, dedifferentiated liposarcoma, myxoid liposarcoma. Now, coming to the fibroblastic and myofibroblastic tumors, the nodular fasciitis, myofibroblastoma, cellular angiofibroma are the benign group. Lipofibromatosis, dermatofibrosarcoma protuberans, infantile fibrosarcoma are intermediate. The malignant group are solitary fibrous tumors, fibrosarcoma not otherwise specified, myxofibrosarcoma, low-grade fibromyxoid sarcoma. The so-called fibrohistiocytic tumors are tenosynovial giant cell tumor, deep benign fibrous histiocytoma in the benign category, plexiform fibrohistiocytic tumor, giant cell tumor of soft parts not otherwise specified in the intermediate. And in the malignant group, it is malignant tenosynovial giant cell tumor. The vascular tumors are arteriovenous malformation or hemangioma, venous hemangioma, lymphangioma in the benign category, Kaposi sarcoma, Kaposiform hemangioendothelioma having an intermediate tumor category, and epithelioid hemangioendothelioma and angiosarcoma are the malignant variants. Pericytic tumors are glomus tumors, not otherwise specified, and angioleiomyoma, and the malignant one are glomus tumors, which are malignant. Smooth muscle tumors have glioma as benign tumors. Smooth muscle tumor of uncertain malignant potential, Epstein-Barr virus associated smooth muscle tumors as intermediate, and the malignant variants are inflammatory leiomyosarcoma and leiomyosarcoma. Skeletal muscle tumors, rhabdomyoma is benign, and the different histologic variants of rhabdomyosarcoma are malignant. Peripheral nerve sheath tumors, the benign category is schwannoma and neurofibroma, and malignant is malignant peripheral nerve sheath tumor. Lastly, the tumors of uncertain differentiation, the benign are myxoma and angiomyolipoma. Intermediate are hemosiderotic fibrolipomatous tumor and myoepithelioma, and malignant are alveolar soft part sarcoma and synovial sarcoma. Now, coming to the etiology, so broadly, there are two causes that are mainly attributed for the sarcomas. First are genetic predisposition. Now, these are the commonly encountered genetic predispositions. Firstly, Lee-Fraumeni syndrome, the genetic variant is in the P53, and any kind of bony and soft tissue sarcomas can arise from Lee-Fraumeni syndrome. Next is hereditary retinoblastoma. The gene is RB, and the sarcoma that can arise is osteosarcoma. Neurofibromatosis type 1, the deficient or mutated gene is NF1. The sarcomas that can commonly arise are rhabdomyosarcoma, liposarcoma, and fibrosarcoma. Gardner syndrome has a defective APC gene, and common sarcomas are desmoid tumors. Warner syndrome has WRN gene deficiency, and any kind of bony and soft tissue sarcomas can arise. And lastly, Ollier and Maffucci syndrome can have IDH1 and IDH2 deficiency and can lead to chondrosarcomas. Now, coming to the environmental factors, now several environmental exposures have been proposed as a causative agent in the development of sarcomas. Now, for example, ionizing external beam radiation to the head and neck area increases the risk of sarcomas. Increased risk has also been reported in people exposed to various radioisotopes and in electrical workers who are near electromagnetic fields. Certain chemical agents have been also implicated in the formation of soft tissue sarcomas. And finally, tobacco has been associated with development of soft tissue sarcomas, especially in the upper aerodigestive tract in users of especially of smokeless tobacco products. But lastly, you have to keep in mind that despite the known risk factors, that is both hereditary syndromes and environmental exposures, only a minority of sarcomas can be attributed to a definitive causative factor. Now let's talk about the clinical presentation. 80% of these patients manifest as a painless mass. Patients with disease in a specific region have specific complaints. For example, diseases in sinonasal tract and anterior skull base have nasal obstruction, proptosis, diplopia, or epistaxis. Involvement of the ear and lateral skull base may present as hearing loss, vertigo, tinnitus, or facial paralysis. Masses that affect the oral cavity can induce dental pain and occasionally complain of loose teeth. And tumors of the neck can impinge on vital structures, causing dysphagia, hoarseness of voice, and even dyspnea. Now, this is a table showing from the MD Anderson Texas group, they have extrapolated data of all the sarcomas that are reported from 1970 to 1999, and given the incidence of sarcomas and the commonest site of origin. So now, if we see among all the histologic types, osteosarcoma has a highest incidence, that is 14.6, and it is most commonly seen in the sinonasal tract, anterior or a medial skull base. Now, coming to the soft tissue variants, the commonest are angiosarcoma and rhabdomyosarcoma, having an 11% incidence. While rhabdomyosarcoma is more commonly seen in the sinonasal tract region, angiosarcomas are more common in the parotid glands and in the neck. Now, coming to diagnosis and evaluation, imaging studies augment the physical examination by more accurately assessing the size and location of sarcomas in the head and neck. So this should be the next step in diagnosing these these masses. In addition, information regarding bony involvement, intracranial extension, and regional nodal activities can be better delineated. Now, regardless of how strongly the history, physical finding, and radiographic studies suggest sarcoma, a biopsy is always necessary to establish a definitive tissue diagnosis. Last but not the least, after the diagnosis is confirmed, distant metastasis should always be excluded, irrespective of the histologic type of sarcomas, since they are most commonly known to spread to the lungs. So, consequent imaging of the chest is always necessary. Now let's come to the TNM staging of soft tissue sarcomas in the head and neck first. The T category is divided into TX, where the primary tumor cannot be assessed. T1 is when the tumor is less than equal to 2 cm in size. T2 when tumor is more than 2 and less than equal to 4 cm. T3 when tumor is more than 4 cm. T4 is when the tumor invades adjoining structures, and it is subclassified as T4A when there is orbital invasion, skull base or dural invasion, invasion of the central compartment viscera, involvement of the facial skeleton, or invasion of the pterygoid muscles. 4B is when the tumor when there is parenchymal invasion, carotid artery encasement, prevertebral muscle invasion, or central nervous system involvement via perineural spread. The N category is divided into two types: N0 when there is no regional lymph node metastasis or unknown lymph node status, and N1 when regional lymph node metastasis is present. Now, the grading of soft tissue sarcomas in the head and neck basically depends on three things. First is the mitotic count score, which is of three types. Type 1 is when 0 to 9 mitosis are present in 10 histopathologic field. The score is 2 when it is 10 to 19 mitosis, and the score is 3 when it is more than 20 mitosis.
Next, 1 sec, Rajesh, 1 sec. HPF is high power field. What? High power field, not histopathologic field.
Oh, sorry, yes, ma'am. High power field. The next category is necrosis score, which is again divided into three types. 0 is no necrosis. 1 is when there is less than 50% tumor necrosis. And 2 is when there is more than equal to 50% tumor necrosis. And last is the differentiation score, where score 1 is sarcomas when closely resembling the normal adult mesenchymal tissue. Examples are low-grade leiomyosarcoma. Score 2 is when sarcomas have histologic typing, certain histologic typing, that is myxoid or round cell liposarcoma. And 3 is when examples are embryonal and undifferentiated sarcomas, that is sarcomas of doubtful type, like synovial sarcomas, soft tissue osteosarcomas, Ewing sarcomas of the soft tissues. Now, based on these, the gradation is basically of 4 types. GX is when the grade cannot be assessed. G1 when there is total differentiation with mitotic count and necrosis score of 2 or 3. G2 when the mitotic count and necrosis score is of 4 or 5, and G3 when the mitotic count and necrosis score is 6, 7, or 8. Now, this is a TNM classification for bone tumors. So, HSCC does not have a specific classification for sarcomas of the bone tumors. This is a classification for all bone tumors of the appendicular skeleton, trunk, skull, base, skull, and the facial bones. The T category is divided into TX when the tumor cannot be assessed. T0 is when there is no evidence of primary tumor. T1 is when the tumor is less than equal to 8 centimeter in greatest dimension. T2 when it is more than 8 centimeter, and T3 is when there are discontinuous tumors in the primary bone site. Now, N category is 3 types. NX is when the regional lymph nodes cannot be assessed, but it has to be kept in mind that in case of sarcomas, the rarity of lymph node, there is rarity of lymph node involvement. So the designation NX may not be appropriate and should be considered as N0 unless clinical involvement is node involvement is clearly evident. So N0 is no regional lymph node metastasis, and N1 is with regional lymph node metastasis. The M category is again divided into two: M0 where there is no distant metastasis, and M1 where there is distant metastasis. Now, the M1 category has been specifically subclassified into 1A and 1B. 1A is lung and 1B is bone or other distant sites. Now, the rationale of subclassifying these M1 is because certain anatomic site metastases in case of bone tumors are associated with poor prognosis. For example, the bone metastasis has a worse prognosis than lung, and the patient with solitary lung metastasis have better prognosis when there is multiple lung lesions. So, in order to keep a documentation of number of lung metastasis, it has been subclassified into M1A and M1B. Now, coming to the staging of prognostic staging of bone tumors. So, 1A is when it is T1 and G1. 1B is when it is T2 and G1 or T3 and G1. 2A is when it is G2 or G3. 2B is when it is T2. 3 is when it is T3. 4A is when there is M1A. When there is N1, it is 4B, or 4B can also be when there is M1B. Now, coming to now highlighting some of the important points of the most common sarcomas that we encounter in the head and neck region. Firstly is osteosarcoma. So it is a primary malignancy of osteoblastic tissue. Most lesions affect the long bones of the adolescent patients, but approximately 10% of osteosarcomas present in the head and neck region. The mandible and the maxilla are the most frequently involved, although other skull bones may be affected. Histologically, osteosarcomas can be subclassified into 7 types, that is osteoblastic, chondroblastic, fibroblastic, small cell, giant cell, telangiectatic, or paraosteal. Among them, osteoblastic and chondroblastic are the commonest. The paraosteal has the best prognosis and telangiectatic is the most aggressive one. Surgical resection that achieve negative margin remains a crucial element in the treatment of head and neck osteosarcomas. Now, this is an article published in the Journal of Head and Neck in 2021 by Shim et al. From the NCDB data from 2004 to 2016. So basically, they wanted to see the patterns of presentation and trends in treatment approaches and outcomes of the different treatment approaches for osteosarcomas. So the cohort consisted of 841 patients, and they were divided into 9 treatment protocols that are surgery only, neoadjuvant chemotherapy with surgery with adjuvant chemotherapy, neoadjuvant chemotherapy followed by surgery and chemotherapy, surgery radiotherapy, surgery chemoradiotherapy, radiotherapy only, and no treatment or palliative treatment. Now, if you see the variable tabulation according to the AJC staging of the different treatment protocols, we can see that the stage 1 according to AJCC had the maximum number of surgery only cohort, and the other cohorts were more common in stage 2. Now, the results showed that the patients who underwent surgical resection as a part of the treatment plan, that is, surgical resection was there in any of the treatment plans, had the best 5-year overall survival, which was 56.6. There was no difference in the overall survival among all the other treatment cohorts on multivariate analysis. However, noteworthy point was that when neoadjuvant chemotherapy followed by surgery and adjuvant chemotherapy was given as a treatment protocol, there was initial 18-month improved overall survival compared to surgery alone, and it was significant. Higher age and higher AJCC stage was associated with significantly worse overall survival. So they concluded that that head and neck osteosarcomas does not demonstrate a long-term survival benefit for patients treated with perioperative chemotherapy or radiation therapy in addition to surgery. Now, next is chondrosarcoma. The chondrosarcoma of head and neck region is an uncommon neoplasm, and only 5%, 5 to 10% of these lesions occur in the head and neck sites. Nearly 50% of these malignancies, however, are found in the sinonasal tract, although larynx is also a common site. Wide excision of all involved structures with negative margin is necessary, especially in cases of high-grade tumors, and it has a high local recurrence rate that is up to 18%. Angiosarcoma is an exceedingly rare type of vascular sarcoma, but approximately 50% of these rare tumors occur in the head and neck region. These lesions classically present as bruise-like macules and plaques on the forehead and scalp of elderly white men. Nodal metastasis is seen in this variant, and it is almost 10%. The ability of these neoplasms to spread subcutaneously over relatively large areas makes local recurrence a defining quality of these malignancies. Now, coming to rhabdomyosarcoma, it comprises approximately 4 to 8% of all pediatric cancers and is the most common sarcoma of childhood. Approximately 40% of all rhabdomyosarcomas originate in the head and neck region, and of these, 90% affect the children. Furthermore, rhabdomyosarcoma accounts for up to 1/4 of all head and neck sarcomas. Now, rhabdomyosarcoma can be broadly classified according to anatomic site and histology. So, according to the anatomic site, they can be of three types: orbital, parameningeal, and non-parameningeal. And histologically, there are four types: embryonal, having the best prognosis; alveolar, having the worst prognosis; and the other two types are botryoidal and pleomorphic. Now, the parameningeal rhabdomyosarcoma basically refers to the tumors arising from the nasopharynx, nasal cavity, paranasal sinus, parapharyngeal space, pterygopalatine fossa, masticator space, mastoid cavity, and middle ear, and are distinguished anatomically and prognostically from other head and neck rhabdomyosarcoma, having poor prognosis when compared to orbital rhabdomyosarcoma, which has excellent prognosis. And the embryonal variant is most common histologic type seen in cases of orbital rhabdomyosarcoma. The basic protocol of treatment is the VAC or VI, that is systemic therapy with vincristine, actinomycin D, and cyclophosphamide, or vincristine, actinomycin D, and ifosfamide based radiation regimen. Now, fibrosarcoma, only 5% of all fibrosarcomas occur in the head and neck region, and among them, 10% of patients report with a history of prior radiation exposure. Local recurrence is a significant problem and has a high rate of almost 62%. In addition, distant metastasis to the lungs is also seen in 12 to 21% of patients. Dermatofibrosarcoma protuberans is a low-grade cutaneous sarcoma that comprises fewer than 5% of all soft tissue sarcomas and only 4 to 10% of all head and neck sarcomas. It is locally aggressive but never metastasizes. Surgical excision with histologically negative margins is the treatment of choice. Leiomyosarcoma account for only 5% of all head and neck sarcomas. The neck is the most common subsite in this region to be affected. Local recurrence occurs in approximately 45% of cases, and distant metastases are also quite common, almost 17 to 35%. The mainstay of treatment is surgical resection with radiation therapy either pre or post-operatively, unless the lesion is very superficial. Malignant peripheral nerve sheath tumor, of all the head and neck sarcomas, 5 to 15% are classified as neurogenic tumors. The most common presentation is a painless, enlarging neck mass, but neuropathy of the nerve of origin may occasionally be the chief symptom. These tumors rarely spread to regional cervical lymph nodes, but have a propensity to recur locally. A worse prognosis is associated with positive surgical margin, high-grade tumors, large tumors that is more than 5 centimeters, and in neurofibromatosis patients. Liposarcoma, fewer than 10% of liposarcomas occur in the head and neck, and fewer than 5% of head and neck sarcomas are liposarcomas. Among them, the commonest site is neck. Histopathologically, liposarcomas are classified basically into two types: low grade, which includes well-differentiated and the myxoid subtype. The well-differentiated type never metastasize distally. There is no distant metastasis, but the myxoid has incidence does metastasize distantly. The high-grade subtypes are the pleomorphic and round cell variants. In general, liposarcoma is rarely present with regional metastasis. Synovial sarcoma is believed to arise from pluripotent mesenchymal cells rather than an actual synovial membrane. Rarely do these tumors involve a synovial structure, but the name is derived from the histologic resemblance to such membranes. The synovial sarcomas of head and neck region are exceedingly rare, and 10% of them occur in the head and neck sites. Notably sensitive to chemotherapy, occasionally manifesting complete response to ifosfamide and doxorubicin. Alveolar soft part sarcoma is a rare neoplasm comprising fewer than 1% of all soft tissue sarcomas. Tumors that are found in the head and neck region, however, originate most commonly in the tongue or orbit in most of the situations. However, there are cases reported of laryngeal alveolar soft part sarcoma. As many as 65% of patients have disseminated disease, usually involving the lungs at the time of diagnosis. Surgical resection is a mainstay of therapy when distant metastatic disease is not present. The undifferentiated pleomorphic sarcoma is a new name for which is previously known as malignant fibrous histiocytoma. 3 to 10% occur in the head neck region. The treatment is preferably accomplished with wide surgical excision of the primary tumor with negative margins. Local recurrence is quite common, and that necessitates adjuvant radiation therapy either before or after surgery. Kaposi sarcoma is a locally aggressive endothelial cell neoplasm universally associated with HIV. There are 4 subtypes: classic, endemic, iatrogenic, commonly occurring due to immunosuppression, and AIDS-associated. The AIDS-associated subtype is the most frequently found within the head neck region. Initially, they present with cutaneous lesions, which are multiple, pigmented, raised or flat, and painless, and they do not blanch. For HIV-associated Kaposi sarcoma, standard treatment first is initiation of antiretroviral therapy, and surgical excision is typically reserved for small lesions, and radiotherapy is for palliation. Ewing sarcoma is rare in the head and neck and accounts for only 1.5 to 4% of all cases. Most patients usually present during the teenage years with rapidly enlarging painful mass located in the sinonasal tract, orbit, scalp, or paravertebral areas of the neck. Optimal treatment of Ewing sarcoma is quite similar, is surgical excision with combination with chemotherapy with a regimen similar to that of rhabdomyosarcoma, that is VAC. It has a high incidence of local recurrence and distant metastasis. Now let's talk about the treatment guidelines as per NCCN. So first, this is a treatment guideline for the soft tissue sarcomas. So depending on the workup, that is once a biopsy has given us a definitive diagnosis, they are broadly, the treatment plan is broadly divided into 2 types. First is for general soft tissue sarcomas, and other is special consideration for 3 unique histologies, that is rhabdomyosarcoma, dermatofibrosarcoma protuberans, and well-differentiated liposarcoma. Now, the first we'll be talking about the general soft tissue sarcomas treatment guideline. So, if it's a stage 1, that is a low-grade tumor, surgery should be the primary treatment with appropriate margins, followed by follow-up. Now, for stage 2, the option is either to give a new preoperative RT or surgery. If preoperative RT is given the treatment, it should be followed by surgery to obtain oncologically appropriate margin. And if surgery is a primary treatment, then it should be followed by RT or observation. In cases of stage 3 disease or selected stage 4, that is when resection will give you acceptable outcomes. The options are neoadjuvant artery or neoadjuvant RT systemic therapy with RT, followed by surgery to obtain oncologic safe margins, and then followed by adjuvant systemic therapy, or we can do surgery followed by RT or RT with systemic therapy. Now, in scenarios when stage 2, stage 3, or stage 3, stage 4 sarcomas cannot give you cannot give resection acceptable functional outcomes, or when it is an unresectable disease, the options are RT, chemoradiation, or systemic therapy, followed by assessment, which shows that it is resectable with acceptable functional outcomes. We should follow the previous treatment guideline. If it is resectable with unacceptable functional outcomes, then, and if it is not previously irradiated, then definitive radiation. And in case of unresectable disease, option is systemic therapy, if not previously irradiated, RT or palliative surgery. Now, in case of synchronous stage 4 diseases, if it is an oligometastasis with limited tumor bulk, and then the management can be to consider for systemic therapy, metastatectomy with RT, or if it's a disseminated disease, palliative treatment options like systemic therapy should be given. Now, in case of recurrence, local recurrence should be treated according to the primary treatment told previously. And in case of metastatic disease, if it's a single organ, limited tumor bulk, which can be amenable to local therapy, options are metastatectomy with or without neoadjuvant or adjuvant systemic therapy. If it's a disseminated disease, it has to be palliative options for with systemic therapy or base supportive care and or surgery. And if there is a isolated regional disease or node, then regional node dissection for nodal involvement with RT or systemic therapy. Now coming to the unique histologies, so for rhabdomyosarcoma, if it's a pleomorphic rhabdomyosarcoma, the treatment should be similar to that of high-grade undifferentiated pleomorphic sarcoma as shown in the slide of pleomorphic sarcoma. Now, if it's a other variant other than pleomorphic rhabdomyosarcoma, then we have to follow the VAC protocol or the VI protocol as described previously in the rhabdomyosarcoma slide. Now, coming to atypical lipomatous tumor and well-differentiated liposarcoma. So, if there is no evidence of dedifferentiation, surgical resection with oncologically appropriate margin should be done. And if there is evidence of dedifferentiation, it has to be treated as other soft tissue sarcomas. Now, for dermatofibrosarcoma protuberance, if the primary option is excision with Mohs or other peripheral and deep end-face margin assessment. In case of unresectable or borderline resectable cases, we can consider neoadjuvant therapy with imatinib. After Mohs surgery or PDEMA, if there is negative surgical margin, we observe. If it is positive, we have to re-resect and then obtain a negative margin. And even after that, if there is positive margin, we have to think of radiation therapy. In scenarios of recurrence, we have to assess if re-resection is feasible, it is preferred. If not, RT or systemic therapy with imatinib. And in metastatic cases, it is a multidisciplinary consultation. Now, let's look at the NCCN guidelines for chondrosarcoma. Now, for bone, the NCCN does not give any specific guidelines for head and neck tumors. It is a generalized guideline for all bony tumors. So, for chondrosarcoma, if it's a low-grade tumor, or a high grade, that is grade 2, grade 3, or clear cell tumor, wide resection is the first option if resectable, or RT can also be considered if it is borderline resectable or unresectable, followed by reassessment. And if there is systemic recurrence, we have to treat it according to metastatic chondrosarcoma. If it is local, and excision should be the first option of treatment. Now, in case of metastatic chondrosarcoma, if it is a oligometastatic disease, there are three options: surgical excision of all sites if possible, or radiation for unresectable sites, and any other clinical trial. And in a widespread metastasis, radiation therapy should be considered, or ablative therapies, or systemic therapy, or clinical trial. Now, coming to the guidelines for osteosarcoma, it is according to the histologic grade. That is, if it's a low-grade tumor or a periosteal osteosarcoma, we have to do wide excision. And in histopathology, if it's a high grade, then chemotherapy should be the treatment followed by follow-up. And in low grade, it is directly follow-up. For high grade osteosarcoma, metastatic and metastatic disease, so for high grade osteosarcoma, neoadjuvant chemotherapy should be given, followed by reassessment of the tumor. If reassessment shows unresectability, then it is RT and chemotherapy. If it is resectable, we have to go for wide excision. And post-wide excision, if there is positive margin, then and there was good response in NACT, we have to consider the same local therapy, same chemotherapy as the drug given in NACT. And if it was poor response, we can consider changing the line of chemotherapy or continue with the same one. Similarly, for negative margin also, if there was good response, we continue with the same chemotherapy drug. If poor response, we may continue with the preoperative regimen or consider changing it. Now, for metastatic disease, similarly, if it is resectable, we have the primary objective is to resect. And if it is unresectable, the options are chemotherapy, radiotherapy. And in case of relapse, chemotherapy and or resection if possible, followed by assessment. If there is response, keep on surveillance. If there is relapse or progression, it can be clinical trial or palliative. Now, this is an article published in the Annals of Surgical Oncology in the year 2016 by Aker et al. Basically, they wanted to see the prognostic value of lymph node evaluation in specific high-risk histology soft tissue carcinomas, where when there is lymph node metastasis, and in such scenarios where lymph node was not assessed preoperatively. So the cohort included of resected soft tissue sarcomas with histologies of clear cell sarcoma, epithelioid sarcoma, rhabdomyosarcoma, or angiosarcoma, and consisted of 2993 patients. Among this database, only 21.3% underwent lymph node evaluation and 5.9% had nodal metastasis. Now, the chart above shows the different histologies that they encountered, and along with that, the different incidence of N0 neck, N plus neck, and also additionally scenarios when the lymph node was not assessed. Now, when below in the Kaplan-Meier curve, when they assessed, they saw that not only in positive scenario, the overall survival was significantly less, but in situations where the node was not assessed, there was significantly poorer overall survival when compared to patients who had an N0 neck. So they recommend a more standardized approach to regional lymph node examination, even though sarcomas are known to have very less incidence of regional nodal metastasis. Now, this is a SEER database analysis published in the Journal of Otolaryngology Head and Neck Surgery in 2014 by Peng et al. It is also from the SEER database from 1973 to 2010, including 11,481 adult cases and 1,244 pediatric cases. Now, in adults, the most common histologic subtype was a malignant fibrous histiocytoma, Kaposi sarcoma, and hemangiosarcoma, while in pediatric cohort, the most common histologic subtypes were rhabdomyosarcoma, malignant fibrous histiocytoma, and osteosarcoma. Now, this shows the tabulation of the overall survival. So we can see in adult sarcomas, the best overall survival was seen in liposarcoma and in malignant fibrous histiocytoma, and the poorest overall survival was seen in rhabdomyosarcoma. In case of the pediatric cohort, also the best overall survival was seen in malignant fibrous histiocytoma and chondrosarcoma, whereas the poorest overall survival was seen in rhabdomyosarcoma. Now, this was an article by the Sloan Kettering Group published in the journal Laryngoscope 2019 by Kim et al. The data was taken from the National Cancer Database to assess the overall role of surgery and radiotherapy in management of head and neck soft tissue sarcomas, and to identify the characteristics of the tumors which are associated with the treatment selection. In addition, they also wanted to see the prognostic factors for overall survival. So 1282 patients were included, among which 53.2% patients received surgery alone, 15.5% patients received RT, and 31.3% patients received a combination of surgery and radiotherapy. The most common most common site of disease was in the nasal cavity, which was followed by the larynx. Now, on comparing the different patterns of care, the patients treated with RT were more likely to have tumors of unknown or poor grade, rhabdomyosarcoma histology, large tumor size, positive margins, primary disease size of either nasopharynx or nasal cavity or sinus. And finally, when RT was the only modality of treatment, it was seen mainly in situations when there was a metastatic disease, and it was mostly associated with chemotherapy. Now, poor tumor grade, large tumors, and metastatic disease were the prognostic factors with worse overall survival. In the subset of patients who received both with surgery with radiotherapy, there was basically no significant difference when radiotherapy was given either preoperatively or postoperatively. Now, a note about radiation-induced soft tissue sarcomas. So, with improved oncologic outcomes, post-irradiation sarcomas are increasingly seen in long-term survivors of head and neck cancers, with an estimated risk of up to 0.3%. In order to call radiation-induced sarcoma, it has to have certain features. Firstly, it has to arise within the irradiation field. It must be histologically distinct from the index lesion, and there must be a latency period of several years between the radiation exposure and subsequent diagnosis of sarcoma. Now, they can arise in any irradiated tissue of mesenchymal origin, and the common histologic subtypes are parallel to their de novo counterparts. Development may be influenced by factors such as radiation dose, age at initial exposure, exposure to chemotherapeutic agents, and genetic tendency. Surgical resection with clear margin appears to offer the best chance for cure, and it is associated always with significantly poor outcomes than stage-matched de novo sarcomas. Now, before ending, I would like to highlight the palette trial, which is to investigate the effect of pazopanib, which is a tyrosine kinase inhibitor, on progression-free survival in patients with metastatic soft tissue carcinomas in situations where the standard chemotherapy regimen has failed to fail. So patients with angiogenesis inhibitor naive metastatic soft tissue carcinomas progressing despite previous standard chemotherapy were randomly assigned to receive either pazopanib 800 milligram once daily or placebo. 369 patients were included in the trial, and the results shows that on the Kaplan-Meier curve we can see that pazopanib had a median progression-free survival of 4.6, and while the placebo group had a 1.6 PFS, which was significantly better with pazopanib. The overall survival was 12.5 months with pazopanib and 10.7 with placebo, although the difference was not significant but marginally better with pazopanib. So pazopanib is a new treatment option for patients with metastatic non-adipocyte soft tissue sarcomas after previous chemotherapy. Now, lastly, I would like to finish or conclude by highlighting the important points in management. So surgical resection with appropriately negative margin is the standard primary treatment for most patients. The incidence of lymph node metastasis is sufficiently low in head and neck sarcomas. So elective nodal dissection is not routinely indicated in absence of palpable nodes, except for a few histologies. Radiotherapy and or chemotherapy in case of chemosensitive histologies are often used prior to surgery, basically to downstage large high-grade tumors to enable effective surgical resection, thus providing better functional outcome. Post-operative RT should be considered following resection with close soft tissue margins, that is when it is less than 1 centimeter, or it is a microscopically positive margin on bone, major blood vessels, or nerve. And chemotherapy has been widely used for patients with advanced, unresectable, or metastatic disease, and doxorubicin monotherapy remains a first-line regimen for unresectable, advanced, or recurrent soft tissue sarcomas. Thank you.
So Rajarshi, when you concluded, you made a point that close margins in soft tissue sarcomas of the head and neck is less than 1 centimeters.
Yes,
is it mentioned in any of the guidelines, or
NCCN mentions it in 2024 guidelines?
NCCN of soft tissue head and neck sarcomas?
Yes.
Yeah, so there was always this query most of the times when we operate on soft tissue sarcomas of the head and neck as to what safe margins are. If should we extrapolate squamous cell carcinoma to sarcoma, or the extremities margins to head and neck sarcomas? If I'm not mistaken, the extremities require a margin of 5 centimeters, right?
Ma'am, NCCN tells it's 1.5 to 2 centimeters.
Okay.
For other,
yeah, Soumyata, tell us. Okay.
Exactly.
So you mean to say that it is the extrapolation of extremity sarcoma, the margins for head and neck sarcomas is the extrapolation of extremity sarcoma? Okay. Okay. Oh, fair enough. Okay, I think point well made.
So I had a few
Another,
questions.
yeah,
Yes,
yeah.
ma'am.
Yeah,
No,
yeah.
ma'am.
Oh, I didn't know you had logged in. Please take over.
I had 2 questions to Rajshri.
yes, sir.
Rajshri, concluding points, you mentioned that management of lymph nodes.
Yes, sir.
Okay, that's always a dilemma. So could you name a few high risk, not high risk, as in few sarcomas of the head neck which have high risk for lymph node metastasis?
Sir, rhabdomyosarcoma, synovial sarcomas, and angiosarcoma.
Any data for this?
Sir, basically this data is from the MD Anderson group which I showed previously of the sites. So
Hmm.
it is from the same paper which I'm quoting. So they have
That
told
paper.
that I'll just show you, sir. So this is the one, sir. So this is by this is the article Sturgis and Potter et
Yeah.
al.
Yeah. So tell us that you mentioned you enumerated rhabdo, synovial, and what else did
Angio.
you say?
Sir, angio.
Angio angiosarcoma,
Yes,
right?
sir.
Now, I'm afraid if there is any uh, 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 because that shows the table, right? If you
Yes, sir.
can, yeah, okay. So where is it mentioned here that they have
No,
nodal
sir.
metastasis?
Actually, so this is basically a table that I've extrapolated from the article. Uh,
Yeah,
but in the article, actually, they have described the salient features of the commonest head and neck sarcomas that we encounter, and there they have mentioned.
yeah. So Rashi, if you do, there is literature, okay, to
Okay, sir.
suggest the scar, sarcomas, basically the synovial sarcoma. Okay, synovial sarcomas, sarcomas like the clear cell sarcoma, okay,
Okay, sir.
epithelioid sarcoma. Uh,
Okay, sir.
uh, these are the ones which have increased risk of nodal metastasis. There are
Okay,
at least five of them.
okay,
Okay,
sir.
and they have a combined risk of up till 16%, and out
Yes.
of these five, out of them, the synovial is the least one actually.
Okay,
Okay,
sir.
so
Okay.
the incidence is less, but in certain of these sarcomas, like I just mentioned, the scar, the mnemonic scar, is something which we have to remember.
Okay, sir.
Okay, and they generally present with increased risk of nodal metastasis. Second is one point
One,
is that
can I just make a Rajeshi, I think just take your presentation towards the end. You presented something about nodes, and there also I saw some table, and I had kept that
Yes.
in mind.
Yes, ma'am.
yeah,
Take them towards the end. Move your presentation. I like that table also. This is. Are you
yes,
alluding to this one,
yeah,
Guru?
ma'am. Yeah, could be this one, ma'am. Okay, but there's another one. If I think it includes all the sarcomas, and then it
Yeah. So
also tells
here also it shows. Yeah, epithelioid,
yes,
clear cell, rhabdomyosa, scar. You said, na? SCAR.
Yes, ma'am.
yeah. So that's the
Synovial,
pneumonia.
clear cell,
Okay.
angio, and rhabdo.
Okay. Thanks. Thanks for letting us know. Okay.
Yeah, so that is the one which is which we have to look at, and
Okay, sir.
what are the how do you diagnose synovial sarcoma?
So, specifically synovial sarcomas.
Yes.
I'm not sure, sir.
Okay. Okay. So your yeah, you should be aware of the translocation which is there.
Okay, sir. Okay.
That may be important. Okay,
Okay.
and also and why is it biphasic? Okay, when we call a synovial sarcoma which is biphasic,
Okay, sir.
monophasic sarcoma, and this is basically pathology but it helps you decide on your treatment management and the line of treatment as well.
Okay, sir.
One point regarding radiation-induced sarcomas, when you were speaking about them,
Yes, sir.
okay, it is important to know that you have you didn't mention there are some criteria. What is that
Yes, sir.
criteria?
Sir, firstly, it has to be within the irradiated field. Secondly, there has
I
to be
got that. I got that. But just as a like just to ask, as in, what is the name of that criteria? And
name. Sure, sir.
the very famous, you know, it's called as the Kahan's, criteria. Okay, for
Okay.
radiation
Okay,
induced.
sir.
Okay, and
Also, Burhan, also does it even mention the duration between
yes,
Yes,
development?
ma'am.
It's about a decade, right? If I'm not mistaken.
yes, madam. Yes, madam.
Yes,
It's
ma'am.
a
Yes.
decade, and it was modified. Initially, it was almost
10.
10 years. Some say 20 years, and then now there is
5.
some modified criteria which says even 4 years.
Hmm.
So it keeps varying, and there is some data on sarcomatoid squamous carcinomas. Okay, but that's a totally different. That's not what we are is the topic of the today's topic. But then many a times because of the pathologist uh, may mislabel it as a sarcomatoid carcinoma, but it could be a radiation-induced sarcoma as well. And it is largely, can you guess, Rajshri, in which areas it is more common in the head neck? Radiation-induced sarcoma.
Oral cavity, sir.
Our oral cavity patients unfortunately don't survive that long. Right. Anybody? Anybody? In the head neck region, where is the largest series or some parotid or somebody can quote the largest series of radiation induced sarcomas, okay, of the head neck? It generally will come from nasopharyngeal carcinomas, friends. Okay, because these are the tumors which are essentially treated with chemoradiotherapy, radiotherapy essentially, and they have a very good survival. Okay, so and it is quite common in certain groups. So from the Sun Yat-sen University, there is a big long like large series published, and it is common again in the nasopharynx region, and that is where you have these radiation-induced sarcomas, which are common because of the long survival as well as the exposure to radiotherapy. If you can come to the concluding slide, I had one more point to highlight
Yes, sir.
regarding the management. See, many a times we have all these uh, sarcomas, and you have to realize that there is a slight paradigm change in the management, okay,
Yes, sir.
over the last few years,
Hmm.
which is for some high grade osteosarcomas, okay. uh, uh, and the treatment, as you rightly mentioned in one of your slides, and those many decision charts you were showing us, one of them or many of them did show the role of neoadjuvant.
Yeah, given.
So in the extremities,
Yes, sir.
and in high grade osteosarcomas, in high grade synovial sarcomas, there is role of some role of neoadjuvant chemotherapy, and it is essentially to not only just downsize the tumor, but also to prevent distant metastasis, because many of them do fail distant. Okay.
Yes, sir.
So, anybody, Mithali ma'am, your thoughts?
Yes, yes. In fact, I think in one of the places Rajesh did show that amongst all the treatment regimen, the ones who underwent neoadjuvant chemotherapy, Surgery
Surgery.
followed by adjuvant chemotherapy had an improvement in overall
Yes.
survival. So
Initial.
somewhere neoadjuvant chemotherapy has a role to play in, the distant metastasis site as well, not just to downsize and reduce functional morbidity. So yeah, I
Exactly.
agree with you, Dr. Buran. Another
Yes.
point, if I can make, another point where neoadjuvant non-surgical modalities actually preferred in sarcomas is embryonal rhabdomyosarcomas, which occurs very commonly in the not just the pediatric age group, but also in these orbital PNS areas. So giving, offering surgery as a first line of management can be extremely morbid in these young children, and they are known to be highly chemosensitive. So many a
Yes.
time they are treated with non-surgical modalities like neoadjuvant followed by chemoradiation, and surgery is by and large conserved for as a salvage situation. This is just one additional point I wanted to
Yes,
make.
exactly, because I also wanted to make that point, ma'am, very rightly, that has to be a take-home message that when it comes to embryonal rhabdomyo, surgery is not the first line of treatment. Okay, it's almost same like for Ewing sarcoma. Okay, so that's something which everybody in the audience,
Another
maybe.
thing, Dr. Buran, we wanted to, if you could elaborate on, amongst all the other cancers, this is one of the unique cancers where the M1 disease is classified into those with only lung and other sites like M1A and M1B. What are
Yes.
your thoughts on this subclassification? So would you consider the ones with M1A as resectable diseases, or what would you do?
So exactly, ma'am. So in this, there is again this role of the newer therapies, which would be very important. That many times these M1 disease, M1A, like the limited oligometastatic disease, they can be amenable to. These are young patients. Many of them are young patients. Okay, and adolescents, and they have these sarcomas, and they may have a metastatic disease. So we can resect them if there is response, if there is some response being seen, because I do feel that it is
Response on the primary or response in the metastasis?
response on the metastatic disease, madam. Actually,
Okay.
we
Okay.
are more worried about the response to the metastatic disease, because essentially the tumor doesn't in sarcomas, the tumor doesn't shrink like, like how we see in squamous carcinomas, but they do respond to some extent. And in the extremities, as long as we have cleared it in the compartment fashion, and with the changing criteria for adequacy of the margin, resection is still possible. And so many a times they do underwent, but then again they fail distantly only. So that is also one concern. So with distant metastasis, the failure again is largely distant, but then to decrease the morbidity, surgery can be offered. Surgery should be considered, and not be written off altogether in limited oligometastatic.
Agreed. I think so. Yes, please. Absolutely agreed. So that's what the drive home message was, this that patients of sarcoma with lung metastasis vis-a-vis patients of sarcoma with metastasis to other sites, by and large, one may err towards surgical or loco-regional control for those with lung metastasis.
Yes, we have RFA, like lot of other treatments which are available, which can be utilized with SBRT. Also, there is good response even in this oligometastatic disease, like limited to the lung at times. And they generally, many times when we do a PET CT, they do present and they are young, and they do present with a small lung nodule. So please, I would also urge that in most of the managements, please, if there's a sarcoma or a suspect sarcoma, please get a PET CT done. because a lot of your management depends on the initial staging and the initial disease burden. So that's I have burnt my hands here, because of inadequate workup and then having a histological surprise. So that's yeah, MRI, yeah, MRI definitely for the local
MRI
extent,
for
local staging.
local staging. Yeah, agreed.
Yes, MRI for the local staging and for the distal metastatic and the overall, you can get a PET CT done. So that's all from my end, ma'am.
I agree. And that's all from my end as well. Is there anything else, Dr. Soumyata, Dr. Rakesh, any other comment that you guys want to make on sarcoma of the extremities vis-a-vis head and neck sarcomas? Or should we conclude the session? Yeah, please do that. Dr. Rakesh, any comments from your end?
Mostly we covered everything, ma'am. And histology, we can confirm that which histology we should go for NACT, like that. So in extremity, we generally go for NACT or neoadjuvant treatment for osteo, Ewing's, rhabdo, and some varieties of liposarcoma.
Okay. I mean, some varieties meaning the de-differentiated variety, I presume.
De-differentiated, yes.
Yeah.
Myxoid, de-differentiated, yeah.
Yeah.
And
Okay. तो वही लिखा है कि facial bones, skull bones. I mean, that is all that they have said. हाँ, तो majority will be T1. Even mandibular osteosarcoma 8 centimeters से ऊपर, I mean, that's what. So majority of these would be T1. But I believe apart from that, the staging also depends upon the grade. Am I right, Dr. Rajashi?
Yes, ma'am.
So it's the stage will not just entirely depend upon the T stage.
T stage,
Stage
yes.
encompasses even the grade.
Yes.
बराबर?
Yes, ma'am.
तो वो फर्क पड़ेगा ना?
And one more thing, ma'am, compared to extremity, the head neck sarcoma, like on most of studies, they show that local recurrence is more common than distant failure. So even
In
the
head neck.
yes, ma'am. So the
Yeah.
staging is also same like other head and neck carcinomas for soft tissue sarcomas, like 2 to 4. That is the
Correct.
only reason. Yes.
Yes, we generally extrapolate, very rightly mentioned Rakesh, that we generally extrapolate our squamous carcinoma size criteria and don't use the extremity but we don't have a separate
No,
size
so
criteria.
Buran, soft tissue sarcomas, we have a separate classification for head and neck. I mean, staging, sorry. But
for
for bone and cartilage, we do not. So
we do
that we need to take it from all other bone tumors as such,
Yeah.
which includes facial bones. So that's the way we extrapolate our question. Okay. Okay, thanks. Sure.
Yeah, nice point. That's a nice point because I think we all missed that. I also missed that. Thanks, Soumya.
Okay, then I think let's conclude the session. But
Yes,
I would urge some other new people to present, Buran, or
yes,
I don't know, Soumita, Rakesh, you guys must be exam going, so I'm not sure if you would be willing to make presentations, but do encourage others to present, na? Okay, so see if they are interested. Yeah. Okay. Okay, thank you everyone. Thanks, Burhan. Thanks everyone else. Thank you.
Thank
Bye.
you, everyone.